Hello, I'm Dr. Lewis Hassel, Professor of Pathology at the University of Oklahoma Health Sciences Center. And it's my pleasure to present to you a short discussion and lecture on some of the benign entities that can occur in ovarian pathology. Some of these will cross the surgical pathology desk because they mimic neoplasms or present with symptoms that require surgery. But many may not even present on your surgical pathology bench and therefore be relatively unknown to us as surgical pathologists. So as we try to bring this topic into focus, I hope you'll think about some of the differential diagnoses that we're considering here and evaluate when these things might need to be considered in your diagnoses. So the first entity, actually something that you will see with some frequency, is a so-called stromal hyperplasia or hyperthecosis. One of my early mentors said this is just thecosis, no need for hyper. But it's typically associated with androgenic manifestations. In other words, some degree of virilization, chin whiskers or something of that sort. And is commonly seen in peri and postmenopausal women as their hormones try to rebalance around the time of menopause. In association with obesity, hyperinsulinism, decreased glucose tolerance, and so forth, it can sometimes be called the Hare-Ann syndrome, hyperandrogenism, insulin resistance, and acanthosis nigricans, although the acanthosis is relatively uncommon. And as patients are younger, then these symptoms for these things can be more severe. The morbidity is primarily related to the hormone imbalances, but if it's associated with neoplasia, that can be a significant problem. The differential diagnosis that we're usually considering is that of a fibromathecoma, which would, in contrast to hyperthecosis, tend to be this would be unilateral compared to hyperthecosis, which is usually bilateral. And fibromas or thecomas typically displace the follicles and other ovarian structures, whereas hyperthecosis just expands the stromal component and is present surrounding corpora albicans and vas vessels and so forth. Younger patients, fibromatosis may enter the differential. That's a little bit more collagenous and so forth. But the take-home point with this is that in any patient who has hyperplasia or endometrial carcinoma and is having surgery for that, you need to look at the ovaries to identify this. If you look, you will find it with considerable frequency. And it's useful to know because that helps to explain some of the driving processes in those processes. So under the microscope, it may just look a little bit like this. Here you see a sort of pinkish blue stroma, quite cellular, spindled and variable. And you may see occasional more pink islands at low magnification, but sometimes you need to come into higher magnification to pick out these luteinized cells within the stroma that tend to have more central nuclei, rounded nuclei, and pale to eosinophilic cytoplasm. Sometimes the cytoplasm can actually be a little bit vacuolated, as you see here in this structure. And of course, these will be inhibin positive as other hormonal activity would be in the, they would also be positive for SF1, for example. Another entity that occasionally comes up is a pregnancy luteoma. This is usually older patients, multiparous patients, and so forth. And this is often an incidental finding that is associated with pregnancy, as the name implies. Typically, this process of virilization in up to a quarter of patients becomes more notable as the pregnancy progresses, and may even result in virilization of female infants who are born to such pregnancies. However, it's a purely physiologic driver in this situation, in that this lesion will regress almost immediately after delivery, and the ovaries will return to normal size within weeks. If on the chance resection is undertaken, because you see it at C-section or something of that sort, this is kind of what it will usually look like. Our thanks to Expert Path for providing some excellent illustrations of these entities. These sort of fleshy brown, tan, red nodules, multiple foci within the ovary that show this sort of beefy appearance. And under the microscope, typically you have a few small follicular type structures. And again, these very characteristic hormone type cells, which may be mitotically active, as you see here. So as you can imagine, with this kind of an appearance, you might have a differential that could include various things that make follicles, various endocrine things, and so forth. And so I've listed here the differential, which would include the steroid cell tumor. But that would be very uncommon during pregnancy and is usually unilateral, doesn't make follicle-like spaces, and would be melon A positive in contrast to pregnancy luteoma. The adult granulosa cell tumor usually, again, would be unilateral, solitary, and not have this multinodular area. And the non-luteinized area would also have typical morphology. Juvenile granulosa cell tumors can make follicles, they can have mitoses, but again, they're usually unilateral. They're not associated with pregnancy. And the background, the stroma behind them tends to be quite myxoid and relatively kind of immature type of appearance. Now, obviously, metastatic carcinoma would be readily discernible on microscopy, but might be confused on gross exam. So the next entity we'll talk about is Hyperreactio Luteinalis, with this very fancy name here. This is actually, again, a physiologic response to a type of hyperstimulation that is usually triggered by elevated HCG levels that may be associated with gestational trophoblastic disease or with multiple gestations, or in patients who are infertile and are undergoing HCG therapy to induce ovulation. Occasionally during pregnancy or in fetal hydrops, you might see it as well. And these are usually bilateral cystic follicles that may have some associated virilization, maybe ascites or effusion, or it may even be just asymptomatic and identified on a routine scan or something of that sort. As you can see, there's kind of multiple cystic spaces. These are follicle-like spaces with varying degrees of differentiation, a little bit of sort of endocrine tissue at the margins and in the stroma. Here's one where you see these large follicle-like spaces, some associated interstitial hemorrhage. I think perhaps because this case may have had torsion as well. And as we come into higher magnification, we see again the luteinization of the follicles, and occasionally within the stroma surrounding the follicles as well, as you see here, little luteinized cells. So the considerations with that, of course, would be polycystic ovary disease, some other process, but usually you'll know there's some sort of underlying process going on to lead you to make that diagnosis. Now, another challenging entity is the large solitary luteinized follicle cyst of pregnancy. Like pregnancy luteomas and so forth, this is often an incidental finding, maybe seen at cesarean section or something. It usually does not have hormonal manifestations. And, you know, if it's symptomatic, you could consider treatment with surgery or something, but often it will just resolve spontaneously postpartum. On the other hand, it can be quite scary because the size can be enormous. 25 centimeters is a not insignificant lesion. And so if there's concern about a mucinous neoplasm or something of that sort, then consideration of excision may be warranted. And the other thing that's a little bit concerning about this, of course, is that you do get some cytologic atypia in terms of nuclear enlargement, pleomorphism, and sort of a smudgy, bizarre chromatin. So here's kind of what we would expect with this. Here's this cystic space lined by these cells with abundant eosinophilic cytoplasm. And you can see the nuclear smudging here at high magnification, a little bit of pleomorphism, but nothing really scary in that sense. So this solitary luteinized follicle cyst can be very large And that's usually where the concern or risk comes into play. You may also have, a few luteinized cells, the stroma surrounding the cyst, if they have found the stimulation as well. In terms of differential diagnosis, we've mentioned the gross differential with mucinous cystic neoplasms, but those are usually multilocular, and so this is a kind of single locule. You might wonder about clear cell carcinoma based on the microscopy with these very eosinophilic cells and some nuclear atypia, but those would usually be keratin positive and not have any inhibin, which you might see more commonly in this luteinized cyst. Cystic granulosa cell tumor, again, usually unrelated to pregnancy and would have some microfollicles as well as this single cystic space. Hyperreactio Luteinalis, usually a bilateral disorder with marked edema, and usually no atypia, as we've seen in this situation. The pregnancy luteoma, again, there's more solid growth in those lesions, not so cystic, and they tend to have a little different coloration and so forth, have multiple nodules that we've discussed. The so-called giant corpus luteum of follicle cyst, again, is usually smaller, even though it's called giant, and has no significant atypia. So that's helpful there. So anytime you see bizarre nuclei within a cyst that's from a pregnant patient, this should raise that suspicion for a large solitary luteinized follicle cyst in pregnancy. All right, well, let's move on to sort of mechanical disorder, ovarian torsion. This is one of the more common gynecologic emergencies, kind of right up there with ectopic pregnancy and a few other such disorders. Again, it's usually in reproductive age women, occasionally younger children and so forth. It's usually unilateral with a very acute onset and maybe some associated nausea and vomiting and so forth symptomatically. We see this associated with other ovarian lesions. So there's usually a reason why the ovary is torsed, and that may be because there's a tumor or a mass there, like a teratoma or an endometrioma, or we have a very large functional cyst or cystadenoma, fibrothecoma, and so forth. And occasionally malignancies can be the inciting mass. Paratubal cysts less commonly, but if they become large, can be the torsion or the pull on the lesion to create this syndrome. So here's an example, very hemorrhagic, oftentimes necrotic, and here this one has a large cystic space, and you can see areas of hemorrhage into the interstitium. This one's been around a little bit, and so the tissue will begin to become necrotic. And I don't need to show you the microscopy because it's all red blood cells, all hemorrhage, all necrosis, depending on how long-standing the lesion has been there and what the underlying lesion is. Occasionally, it's going to be useful to section near the edges or near the margins of it to see if there's some viable tissue there that may give you a hint as to the underlying cause. So these are the things to remember in this situation. You should thoroughly sample these to exclude malignancy because a significant number are associated with malignancy. Now, you may not be able to identify what it is, but just being able to say this was a tumor-related process can be helpful in terms of guiding follow-up. And I've mentioned sampling the peripheral areas where you may be more likely to find viable tissue. Usually the torsion affects both the ovary and fallopian tube, but occasionally in children, you may just have a fallopian tube torsion without the ovary being involved. And patients who are undergoing treatment for infertility can occasionally develop this syndrome because the ovarian enlargements and sort of follicular enlargement associated with that type of hormonal stimulation can lead to an increased risk of this disorder. Okay, moving on to some very common things. Endometriosis, estimated to affect at least 15% of reproductive age women. And if you were looking for just decidual reaction or decidual stromal changes as evidence of endometriosis, you could see that in almost 100% of patients who are pregnant at term. Now, the ovary is the most common site, but other peritoneal surfaces, especially pelvic surfaces, can be involved, as can serosal surfaces of the bowel, occasionally the wall of the bowel, even the mucosa of the bowel, and occasionally more distant sites, central nervous system, elsewhere, and so forth. It seems to have a tendency to implant in areas where there's been prior trauma, like a C-section site or laparoscopy sites, and so forth. In terms of making the diagnosis, you're on safe ground if you see both glands and stroma in making this diagnosis. If you need to do immunohistochemistry, well, they should be hormone positive, the stroma should be CD10 positive, and the cells should be CK7 positive. Of course, in the abdomen, there are lots of other things that are CK7 positive. So you'd like the microscopy to be consistent structurally to give you support for that. And then the immunohistochemistry would just be confirmatory. Now, there are a few things that are suggestive of the diagnosis, and I will sometimes use that term if I describe something like, cellular stroma, suggestive of possible endometriosis. It's possible you see the stroma and not the glands. If you want to do levels, you could do that. Or if you want to find that the stroma is CD10 positive, that again is somewhat more suggestive of that. Seeing hemorrhage and histiocytes or fibrosis, hemosiderin, those features are less specific, but could be, again, suggestive of the diagnosis in the appropriate clinical setting. Now, why is it important to make this diagnosis or to have this treated? Well, obviously, it creates symptoms, and patients with endometriosis can be quite uncomfortable, especially during certain periods of their cycle. But patients with this disorder may merit some additional follow-up to be aware of possible neoplasia, hyperplasia, and so forth that can develop in these lesions, especially endometrioid tumors or clear cell tumors. Rarely we would see other endometrium-derived tumors like carcinosarcoma or adenosarcoma. So this risk of neoplasia in these abnormal locations adds to the impetus to manage this disease appropriately. Well, typical morphology, you often have a very thick fibrous walled cyst with variable amounts of sort of identifiable mucosa or fibrosis or hemosiderin deposition along the surface. And if you begin to see anything that looks like a fleshy nodule, as you see here, in the setting of this sort of fibrous walled discolored cyst, you should definitely be sectioning these areas readily and thoroughly to make sure that you do not have an aggressive neoplasm that has developed in those sites. Now, deciduosis is a sort of related phenomenon. Essentially, it's the decidual reaction due to progestational agents or the hormonal milieu of pregnancy. But this is something that's not usually evident grossly, is not usually something that's causing symptoms. These usually are small lesions and are generally readily identified unless they're occurring in an unexpected setting. Now, there are a few things to consider in the differential diagnosis if these are sort of isolated pickup findings, such as deciduoid mesothelioma or peritoneal tuberculosis, rarely disseminated carcinomatosis. But in that situation, before you make that diagnosis of poorly cohesive carcinoma or sigmoid ring cell carcinoma, make sure that you consider this possibility, because these decidualized cells can look very, very similar to epithelial cells. And sometimes they'll even be, P63 positive and so forth. So here's an example of sort of these multiple nodular areas. We see these not infrequently at tubal ligations in patients who've been pregnant. And you can see there's some associated stroma and even here a few little glands associated with it. On higher magnification, again, you get this sort of very pink cytoplasm, generally small nuclei, although occasionally they can be a little bit larger. Maybe there'll be some associated lymphocytes admixed with the lesion. But you can see with these sharp membranes, sometimes these can be mistaken for epithelial cells. And so recognizing the setting in which you're seeing this, their hormonal background, their age, gestational status, and so forth can be very, very useful in this situation. Okay, well, massive ovarian edema is an entity that I've found quite intriguing since I was a resident. Why does it occur? We don't really understand the physiology behind this phenomenon, but it's a benign disorder, usually in younger women who develop pain in a mass lesion, which can be quite sizable, as you can see, up to 35 centimeters. And they may have some other hormonal changes or something else going on, maybe a fusion or something of like Meigs syndrome. And these lesions tend to have preservation of their physiologic structures, but just have this very pronounced edema and occasionally some luteinization. Up to 10% can be bilateral, and developing torsion is certainly not unheard of in this scenario. Now, grossly, these are massively enlarged ovaries. They generally have a very smooth, pale surface. And on cut sectioning, as you see here, they can have this very glistening, edematous look to them, very myxoid appearing, and can really raise the concern about a possible stromal tumor, like sclerosing stromal tumor can have edematous areas. Fibrothecomas can have edematous areas and so forth. So that differential diagnosis can be a little tricky, but the encircling of normal structures, the pattern of diffuse edema, some preservation near the cortex without evidence of other neoplastic changes will help you. Now, I haven't included a microscopic image because, looking at edema under the microscope is probably about as good a definition of boring as you could imagine. We've mentioned that this spares the normal ovarian structures and the cortex and has a very hypocellular appearance. The vessels can become quite dilated. There may be some hemorrhage, especially if there's been any degree of torsion. And this sort of microcystic appearance can also be present. Now, the differential diagnosis is usually just a fibroma, which will have a mass effect and therefore displace normal ovarian structures rather than encircle and envelop them. And those can become edematous, but if they're displacing normal structures, then think of a tumor. If it's encircling them, then think massive ovarian edema. Krukenberg tumors, of course, also can have diffuse changes and infiltration, but usually you should be able to recognize the neoplastic cells under the microscope. Well, we've mentioned fibromatosis earlier in our differentials, but what is fibromatosis in the ovary? Essentially, this is a lobulated, firm, white surface lesion that's reasonable size, but enlarged, and has a generally quite cellular fibrous stroma. Occasional cysts, maybe, not very commonly. These can have entrapped ovarian elements and sex cord-like elements. So this, it can have this sort of insidious growth pattern in contrast to fibroma, which will, as we've mentioned, displace things. Fibromatosis is like fibromatosis elsewhere. It can encircle existing structures and so forth. Interestingly, these patients may occasionally have hormonal manifestations. And it's not clear whether this is the same disorder as fibromatosis that's described elsewhere. Certainly has a low-grade benign behavior, but whether or not the mutational events and so forth or the predisposing events are similar is not clear to me. So here's kind of what we can see. Here's a little small follicle that's sort of entrapped, and you see this storiform, fasciculated pattern, wavy, spindle-shaped cells, and maybe a few paler cells. You might wonder about some hormonally positive cells in this lesion. Here's a higher magnification view showing that you can occasionally get little sex cord-like structures in these lesions, and here you see a more edematous version of this fibromatosis. So fibromatosis, fibrothecoma, and fibroma. These are three names that are fairly similar and you want to keep straight. So thecoma, that's a stromal neoplasm, usually or may have hormonal effects. Fibromatosis also involves the stroma and can encircle and envelop structures as opposed to displace them, and therefore is distinguishable on that basis. All right, let's switch to some other entities. Again, these are lesions less frequently biopsied, but something to be aware of from a pathophysiologic standpoint. Autoimmune oopheritis is an autoimmune disorder by definition here that can produce primary or secondary amenorrhea and therefore infertility. It seems to be more frequent in the setting of other autoimmune disorders and has some association with anti-steroid cell antibodies. And that may explain kind of the inflammatory process. But it can also be seen in association with other autoimmune endocrine-related disorders like Addison's disease, Hashimoto's disease, and so forth. It's very difficult to predict progression, but ultimately this can cause complete ovarian failure and hormonal collapse in that sense. The treatment is usually using steroids to suppress that and some measure of induced ovulation, I guess you could say, birth control therapy, and or hormone replacement therapy if menopause occurs prematurely. Does not have any neoplastic feature or concerns, but under the microscope, you'll see this very identifiable, not necessarily dense, but identifiable lymphoplasmacytic infiltrate that focuses on the follicle and typically affects the theca layer of these developing follicles or the corpora lutea and some atretic areas. So the theca is much more involved in the granulosa layer, and that may show some degree of sloughing, either due to damage to the cohesive apparatus or others. This may increase as the follicle tends to mature, get closer to rupture, and may be associated with a few other inflammatory cells like eos or histiocytes, rarely non-caseating granulomata. One of the very helpful things is that your primordial follicles and the interfollicular stroma are completely spared from this inflammatory process. You may see some perivascular infiltration in the hilus. So here's what this looks like under the microscope, and you can see here the lymphoplasmacytic infiltration involving the theca layer. Here at the higher magnification, you can see a few plasma cells and lymphocytes with varying degrees of atypia, maybe a rare eosinophil or other cells in this mixture. The differential would include infectious oopheritis, although the degree of inflammation with infection would be usually far greater. Pelvic inflammatory disease, TB, and CMV also would be in consideration. Maybe CMV might have a comparable cellular inflammatory reaction. You can think of possibly just an involuting atretic follicle, but again, these would usually not have the degree of lymphoid inflammation. If you need to, you can do immunohistochemistry, and we'll show a mixture of B and T cells. So this is not a single final pathway, and that may reflect the fact that you have an antibody-mediated process going on. All right, well, moving on to Xanthogranulomatous Oopheritis. These are, again, usually mature adults, but the clinical setting's different. So these people have usually had a fairly lengthy course of pelvic inflammatory disease, of waxing and waning. There's often a setting of intrauterine device or endometriosis, or potentially misuse or abuse of antibiotics. Importantly, however, the enlargement that results from this Xanthogranulomatous Oopheritis can actually mimic neoplasia. And we've seen a few cases, which I'll highlight in the card there, that were thought to be neoplastic and sent for consultative opinion on that basis. Obviously, the differential includes other granulomatous diseases, tuberculosis, Crohn's disease maybe, malakoplakia definitely, and sarcoidosis, although at least in the examples we've seen, the granulomata are not the sort of tight sarcoid-like granulomatous, but for completeness, we've included that here. So this is an example from our collection. You can see how this sort of has a mass effect, very large, and at low magnification, you might wonder about an infiltrative neoplasm here. However, you see that there is a sort of follicular-centric nature to it. And as we come into higher magnification, you'll see there's a little lumina here, or space that has lots of neutrophils. And then the surrounding tissue is all of these very foamy histiocytes with admixed lymphocytes as well. So this is Xanthogranulomatous Oopheritis. Luteinized thecoma with sclerosing peritonitis, again, a quite rare disorder that is, I'm just describing from textbook experience here only, from no personal experience, but described as being bilateral as opposed to unilateral. Mildly enlarged ovaries with sort of an exaggerated, undulated, cerebriform surface. And then a fairly uniform tan to pink cut section. Now the size can be fairly large, but averages, maybe just 2 or 3 times normal, depending on the age. The peritoneum, omentum, and intestinal serosa can also be thickened with this sort of ill-defined and indurated areas. So clinically, this can actually look like disseminated carcinoma, possibly from the ovary or other source. These patients may have distension, they may have ascites and pain. They may have bowel obstruction or other sorts of things. And in the ovary, you get these spindle cells that can have this very bland appearance, but are very mitotically active. And so that can raise concern as well for neoplasia. On the other hand, on the bowel, the proliferative activity seems to be far less profuse and maybe unidentifiable. The differential would include, massive ovarian edema, sclerosing stromal tumors, hyperthecosis based on the ovary, but none of these cause this sort of secondary mesothelial or peritonitis type of pattern with sclerosis and so forth. So here's a gross image of an ovarian lesion, and you can see this sort of rind-like thickening of the ovarian cortex, a very diffuse pattern here without good follicular structures. Under the microscope, here's again this very prominent cortical fecal prominence, and there may be some associated mitotic activity here, maybe a few lutein-like cells, not really good ones here, but you can see there's a few rounded nuclei associated with this lesion. So here's the peritoneal reaction. You see this very inflamed peritonitis with the sclerosis around lobules of the omentum here in this particular slide. So moving on to the next entity, another disorder that, again, usually is not a cause for biopsy or oophorectomy, but may appear in an incidental manner. These patients tend to have very irregular menses, and that's due usually to an excess of androgen that can result in sort of infertility and virilization, maybe associated with obesity or other problems like metabolic syndrome, non-alcoholic steatohepatitis, sleep apnea, depression, other types of tumors that may be related to hyperestrogenism or hormonal drive. These ovaries are usually at least about twice normal size, and they'll have multiple follicular cysts. You'll generally see very few corpora albicantia if you see a resected specimen, and rare or absolutely no corpora lutea because they're not having functional cycles with rupture of the follicle cysts. And so as a consequence, you may get these endometrial hyperplasia or disordered proliferative pattern You may get sloughing rather than true menses and so forth. So I couldn't find a good histologic picture, but here's a nice ultrasound showing you these multiple enlarged ovaries with these very abundant cysts, many of which are very similar in size, that would be considered diagnostic of polycystic ovarian syndrome. Well, pelvic inflammatory disease is another disorder that needs to be considered. Clinically, it certainly has a younger age group. As sexual activity begins, tends to be prevalent at that point. And it's largely due to ascending infection, which infects first the endometrium and then may spread to the tube and ultimately into the ovaries or peritoneum. The etiologic agents, of course, any of the sexually transmitted diseases, but most commonly gonococcus, chlamydia, mycoplasma are seen associated with this. We have recently described a parasitic cause for pelvic inflammatory disease as well. And of course, this is a tragedy in the sense that it can create infertility or result in ectopic pregnancies and all of the complications of that. And if it goes on long term, it may lead to bowel obstruction or sepsis or other systemic problems as well. Tubovarian abscesses, as the fibrosing and healing processes come along, can be late sequelae. As you see here, the tube just adherent to the ovary, and then this sort of chronic fluid-filled cystic inflammatory space. Under the microscope, you'll tend to get dense lymphocytic infiltration, some plasma cells most likely as well in that, and you may see occasional neutrophils out of a tube lumen or in the abscess formation areas that you have associated with these. So I hope that's brought some of the benign conditions into focus for you. I know this is kind of a traditionalist approach, but we hope that if you have questions, you'll post those in the comments below. And if you like art, you'll know that this particular painting comes from the Hudson River School of Early American Artists, Thomas Cole. And this is held in our own local Museum of Art, the Oklahoma City Museum of Art. So if you'd like to see it up close and personal, that's where to find it. But me, you can find on this channel. And if you want to get notice of our subsequent releases, please hit that subscribe button. And we will look forward to seeing you on a future release from our channel. And again, thank you for your interest, and hope this has been helpful for your education. So until next time, thanks for joining us.